We're good. Okay, good morning, everybody. Welcome to our penultimate grand rounds of the season. We have this one in our high value series, and then a special speaker next week, Dr. Tim Gobble, who is an alumnus of our program, who's going to come talk to us about his experiences in Malawi. And then we'll be taking a break for the summer. But today we have a very special guest visitor, Dr. Louise Aronson. Dr. Aronson is a professor of geriatrics at the University of California in San Francisco. She's a graduate of Brown University and Harvard University, and she is the director of, or has served as the director of the Northern California Geriatrics Education Center, UCSF's Pathways to Discovery, and the UCSF Medical Humanities. Her interests are in optimizing healthcare for older adults, medical education, reflective learning, integrative geriatrics, and public medical writing. In fact, she is also a skilled writer. Her work has been featured in the New York Times, in Washington Post, New England Journal of Medicine, and Lancet. And in fact, she has a new book that just came out called Elderhood: Redefining Aging, Transforming Medicine, and Reimagining Life. I understand she's going to be giving a reading at Powell's Books tonight, so if you need more of your Aronson fix, you can join her this evening. And our own Marion Hodges has described Dr. Aronson as a true geriatrics luminary in their field, and so we're very pleased to have her. Welcome, Dr. Aronson.
Thank you. It's a pleasure to be here. I'm having a great time in Portland, which I suppose is not surprising, but you all are also terrific hosts. So I'm going to be talking about optimizing medical care for older adults. And yes, there will be mention of Steve Jobs, but you got to hang on till the end for that. So when people talk about aging, and this is in medicine or in the media, we tend to tell two stories, basically. One story goes that if you eat your kale and blueberries, as an American, this actually does not work in other countries, but as an American, you can live forever, not die, and in fact be like these people as you grow older, right? It's just all about doing the right thing, healthy aging, successful aging. There is actually a terminology for these two, which is exceptional elder. And they're held up as the standard, even though if you look up the definition of exceptional, it means you're not the standard. So there's a problem with this first story of aging. The bad news is there's a problem with the second story too, which is that the silver tsunami is coming. Now there is no upside to a tsunami, right? It just brings destruction. It destroys lives, it destroys society, it destroys buildings. There is nothing good about that. So what I'm going to be doing over the next 45 minutes or so is trying to challenge you to consider how you think and feel about old age and the relationship between your thoughts and feelings and the facts. It's sort of a false facts, true facts is kind of popular these days, as you might have noticed. I'm going to compare a little bit internal medicine, which was my first specialty, and geriatric medicine, which is my current home. I think both do wonderful things, and also that they're quite distinct. And we'll identify changes to medicine and medical education that will improve care and lives for providers and patients alike. So, as was described, I am from San Francisco. This is a picture of San Francisco. And some years ago, I had a doctor's appointment. It was at the end of the day, and it was the middle of December. I had conveniently arranged my small surgery just before the vacation. And I went into a medical center, not my own medical center. As I was walking in, I spotted on the curb an old woman. So she was probably in her early to mid 80s. Actually, I know from after the fact that she was. She was fairly nicely dressed, so sort of looked like a professional, and had a walker and a cane and a bag, and appeared to be waiting for a ride. So in I went for my appointment, and when I came back out, I was rushing off to do all the things that we all have to do in the evening, particularly those of us who see patients and can't possibly finish our charting in clinic. So I just spotted out of the corner of my eye like something, and it turned out to be this same woman. So at this point, night had fallen, and there were cold breezes. She was looking a little disheveled, And I had that moment where you know what the right thing is and you know what you need to do. And then I turned around and I said, "Are you okay?" And she said no, that her ride hadn't shown up, and that she had something on her phone that called a cab, but it sent it to her house. And then she showed me her phone, which was dead. So I called a taxi for her and started moving her forward towards the curb. And during that time, I began learning about her. So she was in her early mid 80s, and she had recently retired. Was having some health issues, and in fact, had had two sort of small hospitalizations in the previous year, medical problems that were easily fixed, but which had basically destroyed her life. Anyway, the cab arrived, we were having a nice chat, and I moved her forward with her walker and cane and both our bags towards the taxi. And as I reached to open the back door of the taxi driver drove off, having seen her, this woman I call Eva. I could not believe it, and I was about to call the cab company, and she said, "Oh, this happens all the time." I had no idea, right, as not an old person. So I called another taxi. I'm about to call another taxi, but another taxi rounded the corner, so I hailed it. It stopped, it saw her, and it drove off. So, needless to say, I drove her home. But I'd like you to think of the taxi's approach to Eva as very much the way society and medicine often approach older adults. It's essentially a metaphor. So let me tell you something I learned about Eva over the next hour as I got her up the 47 steps to her rent-controlled apartment. So you may have heard that rents in San Francisco are insane, right? So for a small apartment these days, it will go for $6,000 to $8,000 a month. So she had one in the hundreds of dollars per month. And as far as she was concerned, she was only leaving feet first. But I learned that she got most of her care actually at my medical center. And here's what I learned about the last year of her life. She had had 34 medical visits in the last year. Now, this was a woman who had been working as an accountant, right? So an active, engaged person. She had 9 in ophthalmology, 5 in radiology, 4 in pulmonary, 4 in GYN urology, 4 in oncology, 4 to the podiatrist, 2 to the emergency department, 1 to cardiology, and 1 to general medicine. Now, you may also notice that the skew is typically American, with lots of specialists and subspecialists, and a single primary care visit on the bottom. This is important because the World Health Organization currently ranks the United States 36th in health outcomes, and an article in The Lancet in February said that we will fall to 64th by 2050 if we continue with this approach. All the health systems that do better than we do prioritize primary care. So she also had many, many missed visits, things like the taxi never showed up, which had a whole new meaning to me after meeting her, and many, 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 many phone calls. She had the 2 hospitalizations I mentioned, and 1 skilled nursing facility stay after her second hospitalization, and it was that experience that truly dismantled her life and function. She was also on 17 prescribed medications, and they were prescribed by at least 5 of her physicians. Some duplicates, needless to say, with that many doctors or chefs in the kitchen. Now, here was another thing I learned from Eva. Because she had these steps and she was having more and more trouble walking them with her arthritis, she sometimes had to pay to be transported. Now, that was $3 a step, times her 47 steps. She had to obviously go down and get back. So that was $300 per appointment and $10,000 a year. Now, she was fortunate in that she had had a job that she could afford this, at least for a while. But imagine all the people who can't afford this and can't afford to move. So I got her permission to look at her medical record, and I did that the next morning. And what I found was that she saw all kinds of colleagues that I have known since my training days who are fantastic doctors and really nice human beings, and who had charted carefully and clearly liked her and were doing a good job. But here's what was present in their notes. Diagnoses that are familiar to all of us: hypertension, asthma, hyperlipidemia, glaucoma, chronic kidney disease, urinary incontinence, DJD, and lymphoma. They all had given these diseases guideline-based disease management. They also noted, several of them noted, pain and mobility issues that were getting worse. And in fact, one person wrote, Eva does not walk much in her own apartment, but does utilize a walker. Often, however, she is semi-chair bound. Now, having noted these things, here's what was not in any of these notes, and I spent a long time reading many notes. There was no evaluation of her joints. There was no evaluation of her gait. There was no pain management. There was no functional assessment, medication review of her 17 medications, and bear in mind that for older adults, you have much higher risk because of metabolism, because of declining kidney and liver function, because of a change in the water to fat ratios in our bodies as we age, because of drug-drug interactions, drug-disease interactions, disease-disease interactions, and she's on 17 medications. And we also know that older adults who are on 4 or more medications are at increased risk for falls. But there was no medication review. There was no discussion of her goals and priorities. And while Eva was a charming person, she had never been married and had no kids or relatives in the area. So she's in her 80s. Even if you're a healthy, functional 80-year-old, your chance of death is higher than if you're a healthy, functional 50-something-year-old or 30-something-year-old. And there was no discussion of her priorities or goals. There were no physical therapy or social work referrals. We don't all have to be able to do everything, but we know we have colleagues who can help us. No care coordination and no advance directive. And I will just say, I don't know what it's like here, but this is pretty typical at my top 5 in the country ranked institution. So what I see often with a patient like this is something that's entirely understandable given how we train things and how our health system sets up to send us in certain directions. But it reminds me of a medical student who was working with a colleague of mine and was sent for a day to a program for all-inclusive care of the elderly. And I understand you have that here as well. These are programs that take people who are eligible for nursing homes and keep them at home with some support for their basic care needs at home, with medical care, with food and showers at the center as needed. And here's what our medical student said. That's not medicine, that's just taking care of patients. No irony, like he literally didn't realize what he just said. And my colleague said that she could not respond. It was just like she just couldn't think of anything to say until about an hour later, and then all she could think of was this. So it occurred to her that we might be giving medical students the wrong impression of the goals and purpose of medicine at our wonderful medical school. So this really matters. This is probably not news to most of you, but although older adults are 16% of the population, they are 36% of healthcare spending. And when you see a person like Eva, it turned out all her problems, all her diseases, her asthma, her hypertension, her lymphoma had been treated. The only active problem she really had was the glaucoma. So she was doing all those doctor visits for stable diseases that might well have been managed not by a specialist, but by the occasional primary care person. And yet the things that were really changing her life, her pain, her inability to get around, none of those were addressed. And I just want to emphasize again, this is not because these were bad doctors. These were some of my best and favorite teachers. What they were doing was what they were taught to do, and what they were paid to do, and what they were promoted to do. But it wasn't what their patient needed. So this also matters because people often talk about a baby boom blip. Well, the news is there's no blip, right? So in school, I learned about the population pyramid. That in societies, for as long as we could remember, there were tons and tons of children, and then fewer adults, and then very, very few old people. And that was not always true through human history and across all cultures, but it has mostly been true. And now that's changing. Except for in certain parts of Africa and a few other places on the planet, we are changing to more of a pillar or rectangle, which means there's about the same numbers of kids, adults, and older people. And in fact, the numbers of older people are actually older than they were. So there's something called the longevity dividend, which we acquired through the 20th century as a species. And it's an additional, depending on who you are, 20, 30 years of life. And those years of life come in elderhood, not in childhood or adulthood. So this is the new normal for the human species. As far as demographers know, this is, as far as their projections go, this is what is happening to our species. And yet I would argue that our medical training system and our medical reimbursement system are still set up for the early 20th century. My father trained in the 1950s, and people still do the same rotations he did, pretty much. So we end up with bad medicine. And some of this is historical, but if you actually read historical treaties on the aging population from 1910 or 1960, you hear about the demographic shift that's coming, how we need to start paying attention to older adults. Actually, the Gray Panthers were formed in the 60s at the same time as, the feminists and the civil rights movements to try and advocate for this now silver tsunami that people are pretending they didn't know was coming. So where do we end up in medicine? And the other thing I want to emphasize is that the way we're handling medicine for older adults is actually paradigmatic of the problems in how we're handling medicine for all of us, right? Because we're ranked 36th internationally, not just because of our care of older patients. We're ranked 36th internationally because of our care of all patients. And yet we can use our care of older patients as a way of thinking about how we're failing everyone. CDC estimates that 75% of individual health is determined by social determinants of health, many of which would fall into that medical students thing as that's not medicine, right? Medicine these days, newly in the last 50 years, is considered really hardcore science. It's considered drugs. It's considered procedures and technology. It's not considered working with a patient on their behaviors. It's not considered housing or food or opportunities for healthy living. So it has really narrowed in a way that may be doing us harm. CDC similarly estimates that 70 to 80% of chronic disease is preventable and might indeed be prevented with very different priorities. Medical care itself is only preventing about 10 to 15% of that, and those are some generous estimates. But 97% of the US healthcare dollar goes to things after people have diseases or chronic diseases, care after the fact, and to our administrative costs, which are unequaled on the planet. You can actually combine the administrative costs of a handful of other nations, and they will not equal the costs of administration of all our various competing and inefficient healthcare programs in this country. And because our rankings are so low, we actually have the most medical care of any country and the most advanced medical care, and yet our outcomes are not so good. So we know that more medical care does not equal better health or better care. Essentially what we do is we let the horse out of the barn, right? And then we go racing in with our intensive care units and our hospitalizations. And in fact, medical systems are incentivized. They get paid more for hospitals, right? We say we don't want people in the hospital, but hospitals want to be full. That's the incentive system, right? And we will pay for an older person like Eva. Our health system, no matter what kind of insurance she has, including Medicare, and we know Medicare reimbursement is not great, will pay to have her in the ICU for months, getting care that costs many thousands of dollars a day, paying $500,000, $1 million for a surgery and all its complications. But it won't pay to get her in and out of her apartment, or to give her the exercise classes that would enable her to keep functioning. And you may say, oh, she's in her 80s, exercise won't change her life. Well, I'm going to show you some data in a bit that will prove that that's actually not true. And so when we're paying for intensive care and not for preventive and strengthening care, we're actually not practicing evidence-based medicine. So some lessons. Lesson 1. Too often what we consider medicine isn't the best medicine. So I decided to take, there are so many examples of this, but I thought, well, let's go with the number one killer, shall we? So heart disease. Statins, some people argue that they should be in the water. That's probably not true. I think we can all agree on that. But they probably actually are in the water because of how we dispose of drugs. But that is a different topic. I'm not going to go there any more than I just did. So the evidence for statins, and by the way, this is from a really neat website called Number Needed to Treat. So if you really want to get a sense of risks and benefits, they do some great analyses, saving you the trouble of doing it yourself. So over a 5-year time frame, the number needed to treat of patients is 104 to prevent one heart attack. Now, of those patients you treat, 1 in 50, so 2 people will develop diabetes. Now, if you stop the statin, this generally reverses. 1 in 10 will have some sort of myalgia, which may affect their ability to function, right? So muscle pains, and a percentage of those will get rhabdo and end up in the hospital. The ones with rhabdo, obviously, we find out about. But we often poo-poo things like muscle pain. But particularly if you're an older person with some arthritis or frailty already, that muscle pain may be enough to have you lose function in ways that you don't recover from. So this will prevent, number needed to treat is 83 to prevent 1 fatality over 5 years, and 39 to prevent 1 non-fatal MI over 5 years. So let's look at the Mediterranean diet, right? A non-medical intervention in theory. I don't know about you, but the hours I got in training in nutrition and nutrition counseling in medical school either were 0 or were so small that I have absolutely no recollection of it. So time frame, 1 year versus 5, right? So quicker accrual to benefits. Number needed to treat, 61. Outcomes, not just MI, but also stroke and death. Side effects, none, unless you consider that Mediterranean diet is also shown to lower people's risks of hypertension, diabetes, certain cancers, arthritis, various other things that tend to happen to us in adulthood and elderhood. Maybe positive side effects, but we don't actually have a language for that, which is sort of interesting if you think about it. So treatment, number needed to treat, 30 to prevent a fatality and 18 to prevent a non-fatal MI. And yet it's so easy to give someone a statin, isn't it? It doesn't take that long, the costs are greater, but to counsel them on a Mediterranean diet, to get them into a test kitchen, to learn how to do that, to figure out what to do in our neighborhoods. There's actually this amazing program I heard about recently in San Francisco, which has a wait list of many thousands, but it takes low-income people, particularly in neighborhoods which are sort of food deserts for things like fruits and vegetables, and they get a voucher for $20 a month. Now, when I heard $20 a month, I thought, like, how is that going to make a difference? I mean, obviously, it depends on where you shop. I'm clearly shopping at the wrong places, but I thought that can't change lives. So it turns out it absolutely changes lives. So people get 6 months worth of vouchers, 1 a month, and they begin buying more fruits and vegetables, and it does a bunch of things. If you have enough people in the neighborhood, the little neighborhood shops can now afford to stock fruits and vegetables because enough people are buying them. And according to their data from the last 2 years, 70% of people continue to buy fruits and vegetables instead of unhealthier foods once their vouchers run out. Transformative, right? For the neighborhood, for the neighborhood's income, for what's available, and for a huge number of people's behaviors. So there are ways we could be doing this, but that's not medicine, right? That's just taking care of patients. Switching topics here, an evidence map of Tai Chi. There are over 30 studies, and depending on what you're looking at, way more studies of Tai Chi. Proven to prevent falls, more effective than brisk walking in the sense that it also improves balance, flexibility, and lower extremity strength, improves pain generally and from arthritis, increases physical functioning as measured by the SF36. People have increased energy and feelings of relaxation, suggestions of improved cognition. That actually makes it seem like it's definitively proven. I don't want to mislead, sorry, I was going for brevity there. Helps in management of hypertension and COPD. Really, really, really good data. But let me remind you again that this will prevent falls. Preventing falls prevents fractures. But do any kinds of health insurance pay for people to do Tai Chi? Well, actually, some of the Medicare Advantage plans are starting to. Why? Because they are incentivized to save money and to keep people healthy. Now, there are lots of problems with them. Many are for profit. And to make money off lives is something we could ethically debate. But they're paying for it because it keeps people healthier. Because there is proof, there is abundant evidence that paying for exercise classes for people of all ages keeps them healthier. And when you're in a capitated system, you want to keep them out of the hospital so that you make money off them instead of losing money off them. But what does traditional insurance do? What do we prioritize in our health system? Well, we're not going to pay for you to exercise. Here's what we will pay for after you fall. We will pay for the ambulance to come get you and transport you to the emergency department, where we will do a number of scans and put in an IV and draw bloods and call some consults, and then we'll send you upstairs to the hospital. And we'll prep you for surgery, and you might have more consults, and then you'll get anesthesia, and you'll have OR time, and you'll have surgery, and you'll have post-op time, and then you'll be back in the hospital. And then chances are, particularly if it's a hip fracture, we didn't get you into the OR in 24 hours because we were calling consultants, you will probably be delirious, and then you'll have other complications, and then we'll have to send you to SNF. And I know in our managed Medicare program at UCSF, the pain point cost-wise now is people going to SNF after hospitalization. So we will pay for all that at a cost of tens of thousands of dollars, but we will not pay for that same patient to get some Tai Chi, which would prevent falls in not everybody, but in a significant proportion of people. Okay, let's take something else that's often considered not so medical, incontinence. Well, it turns out incontinence is pretty miserable. Like we think, oh, well, you know, that doesn't kill people. Well, you know, humiliation tends to lead to social isolation, and social isolation is equivalent to smoking 15 cigarettes a day. It basically affects people's emotional life, their relationships, including sex, which, yes, older people do have sex, exercise and sport, employment, travel, sleep, all kinds of adverse consequences of incontinence, and it is very, very common. So we see ads on TV for adult diapers, but we don't actually talk about all the ways we might prevent it. And actually, in the Annals of Internal Medicine just a couple months ago, there was an article that compared the various surgical treatments for which all insurance will pay and the pharmacological treatments for which all insurances will pay to behavioral therapy. And their conclusion was, behavioral therapy alone or in combination with other interventions is generally more effective than pharmacologic therapies alone. But again, behavioral therapy, is that medicine? If doctors don't do it, if other people do it better, is that medicine? And, you know, are we taking care of patients or are we practicing medicine? And why aren't those two the same thing? Lesson 2. The earlier you start, the better and cheaper the outcomes. So I kind of love this. I did take one economics class in college, but I didn't learn nearly enough about it. And it's just so clear that this coming in the horse out of the barn thing is way more costly than preventive interventions. You know, if we were doing more primary prevention, less secondary and tertiary, and most of medicine, let's face it, is tertiary, there's a certain amount of secondary. It would be much less expensive. So when we talk about there's just not enough healthcare dollar, right, we're such an expensive system, that's not necessary, right? We could actually shift our priorities and what we're paying for and save money. We don't have to ration the super expensive horse out of the barn care. We could actually just shift what we pay for, how we spend our time, and what we prioritize, and that would make things cheaper. And in fact, that's why healthcare, it's not that this isn't a problem in all countries, right? Even people who have a single payer healthcare system are now having trouble with healthcare. So I'm not diminishing the problems of all the new science and all the things we can do for people, all of which are so helpful and absolutely save lives. And I'm not in any way saying not do that. What I'm saying is also, and all the more effective treatments, systems, do much more of this primary prevention, which would save enough healthcare dollars that we could use these newer, more expensive treatments for the people who need them instead of moving towards rationing, which is, some people would argue, anti-American, and we'll see how that goes, but I'm also not going to wade into that morass. Lesson 3. We're not nearly as evidence-based as we claim to be, which hopefully I've already shown in a number of ways. But let's just take this article that was out last week. Risk of hospitalization for serious adverse gastrointestinal events, including death, associated with sodium polystyrene sulfonate use in patients of advanced age. So you may know this as K-oxalate, the medicine given when people's potassium goes up. So potassium is more likely to go up if you are sick, if you have kidney disease, all sorts of things that happen more commonly in older people. So as with most drugs, this was a drug given quite often to older people, and yet it was not studied on older people. Because until January of this year, the NIH had no stipulation for inclusion of older adults in research. 20 years ago, it instituted stipulations to include women and minorities and children in research. Now that has not gone perfectly, but they excluded older adults until the inclusion across the lifespan mandate went in late January of this year. And what that meant was that in different studies, it's anywhere from 65 to 80% of studies, even on diseases that primarily manifest in older people, excluded older people mostly by one of two mechanisms. One was age, just straight up. Nobody over age 70, or nobody over age 65. And the second way was saying, like, nobody with comorbid conditions, right? So if you have dementia, forget it. If you have sometimes hypertension or heart disease, or you've had a cancer, or you have diabetes, or you have Parkinson's, or any number of the conditions that people often have. So what this study looked at was adverse events. And what they found was that the rate of adverse events was entirely unacceptable. Lots of intestinal ischemia, hospitalizations, and deaths. And an accompanying editorial said, we need to take this off the market. There needs to be a black box warning for people over age 65. I don't know, but when I was a residency in the 90s, I gave this to people over age 65 all the time. In the 90s was a few years back now, so it's been happening since then at least. And this is what happens when we study older people, right? We find that their bodies respond differently, which really shouldn't come as a surprise. Like, you know, every now and then I feel like medicine goes counter to common sense. Like, I'm all for evidence-based medicine, but if you put a 15-year-old, a 25-year-old, a 45-year-old, a 65-year-old, an 85-year-old, and a 105-year-old out, we can all tell which is which, right? And that's because they're different. They're different anatomically, they're different physiologically, they're different in their behaviors, they're different in their priorities. And when we study older people, we find that their bodies respond differently to drugs. Surprise, surprise, right? But what was happening for all these decades while people were getting Kayexalate? They were saying, oh, they had a bad reaction because they're old, right? We blame old age for things that are the results of our policies and our choices. So we need to have that. The really good news about that is it's not that hard to fix. Let's actually study the drugs we give to older people in older people, right? We can change our policies and choices. The thing to do is pretty obvious. Okay, so I mentioned earlier about exercise evidence. So I'm now going to show two articles from the mid-90s. So this was around the time I, who had never thought of becoming a geriatrician, became a geriatrician. And part of it was because I ended up with a clinic with lots of older people in it, just by chance. And I found, number one, I loved taking care of them, partly because they have such long lives. The medicine was fascinating and interesting. And partly because I realized that I was at maybe one, certainly one of the best primary care training programs in the country, and I hadn't really been taught how to take good care of them, and that didn't seem right to me. Anyway, so here's one article by Goralnik et al. Lower extremity function in persons over the age of 70 years as a predictor of subsequent disability. Right, so this is an in-office test that's easy to do. I'm not going to ask how many of you do this routinely, but we know that subsequent disability costs a lot of money for the healthcare system and is absolutely miserable in the life of the human being, right? So we have a screening test for this, and we have interventions that work. So this is also from the middle 90s, Maria Fiatarone. So, and I just also should point out that both articles were in this little journal you may have heard of called the New England Journal of Medicine. So I'm not drawing from an esoteric literature that we shouldn't all know. So what Maria showed was that for people in their 70s, 80s, 90s, and I believe into their early hundreds, exercise training and nutritional supplementation, but really exercise training, reversed frailty. Right? People got that you can build muscle at any age, you can increase strength at any age, but do physical therapists know this? No, I have to write really specific things on my prescription about increasing resistance training and working on balance if it's an older person or a frail person. And many of them, like many of us, right? Like I was at this great internal medicine training room, you don't learn what you need to know. So this is evidence, right? And it's been shown again and again. And yet we don't do that screening test because it's not an MRI that we can send for and pay thousands of dollars. It's not high tech. And yet it evaluates people for the thing that most people fear most about old age, right? I mean, people don't want to become disabled. They don't want to become frail. We have a test for that, and we have interventions for that. And we are not rewarded for doing this kind of really good medicine. Lesson 4. To optimize care of older adults, we also need to treat ageism and address aging. So this is a map of ageism internationally. I'll try and speak loudly enough, but Western countries, more Eastern countries, level of respect, higher is better, United States. Not so good. Good to see this as an opportunity. Now here's some data from the Baltimore Longitudinal Study of Aging. This is also this remarkable researcher at Yale called Becca Levy, who's done all kinds of stuff about what she calls age stereotype. So there's a ways of evaluating ageism. So this is a bit like if the person is older, it's a bit like internalized homophobia or internalized racism or internalized sexism, right? Only it's way more common than any of those things, internalized ageism. So people who have positive ideas about aging, like old age, I'm looking forward to old age, it won't be so bad, versus people who think like, old age is an unmitigated disaster. I'm not looking forward to it. I'm really going to pretend I'm not getting older for as long as I possibly can. So you compare those two groups, and she's done that in a variety of ways. So in this way, they're looking at hippocampal volume. So the hippocampus, your memory, we all want our brains to work as we grow older. And people who have more positive attitudes about aging have larger hippocampal volume as they age. You can think of some confounders, and she has addressed many of those. I don't have time to go into everything. But she's also shown this in a variety of other ways. So people with positive age stereotypes tend to have their first cardiovascular event 7 years after. People who have negative age stereotypes. Now for here, there are mechanisms that are somewhat obvious. If you think aging isn't so bad, you're more likely to stay active and to preserve your health. I mean, this may well be the mechanism is behavior. Instead of fatalistically saying, I'm old now, I don't feel very well, I'm going to sit in my chair for the rest of my life. So it really makes a difference how people see old age and the opportunities of old age. And we're not necessarily doing a great job of telling them that, yeah, even if you're 93 and you've never exercised in your life, actually you can build muscle, you can increase function. And in fact, because you are so ill-conditioned, right, you can achieve greater benefits than a person who's out walking 3 miles a day, right? The delta, the health benefits from a change from an unfit person are far greater than the same increment of change, behavior change from a person who's already fit or trim or any of those things. She's also shown similar data with Alzheimer's markers in cerebrospinal fluid, with recovery after hospitalization for a variety of different reasons. So really interesting data and replicated at other sites. So now I'm going to explicitly challenge some myths about old age. And I think we all have some of this. I sort of, I went into geriatrics thinking I was doing this wonderful thing. And I think at some point around when I turned 50, it occurred to me that, oh, this meant me too. Like, it's sort of fascinating. I think I thought I was on some sort of anthropological mission. So I relate to all of these. I'm not, I think we all do this. We're all part of the same ageist culture. And it's been really helpful to me to think about what I do and what I say, that even when I mean well and I've devoted my life to this, you do these things because it's bred into us, and you don't need to keep doing it. So the first one, old age is miserable and to be dreaded. So There is actually worldwide data on this. It's bad if you're in like the bottom fifth or two of countries in terms of economics. You know, if you are in a country where everybody is impoverished and starving, and then, you know, life doesn't necessarily get better as you get older. But for people in the United States, by and large, and in other similar countries, well-being begins going up in the later 50s, and it just goes up. Right? So this has been shown across studies, Gallup World Polls, right? A variety of other polls, so tens of thousands of people. Now, the smart scientists in the group might say, well, there's obviously like an answer bias, right? Because if you're completely disabled and homebound, you're not going to respond to the survey. There probably is some of that. They do try and account for it in their polling, because even if you're homebound, you can answer your telephone. This is similar data from a different study showing that happiness goes up as people get older, anxiety goes down. This is good news for like all the adults here feeling stressed out by their jobs. Like look, life is gonna look way up, right? Life satisfaction goes up, right? But when we tell the stories about old age, we tell the aches and pains, and did you know so-and-so was in the hospital, and oh, I can't do this anymore. But really, as people get older, they're spending more time doing the things that they want to be doing and less time doing things they don't want to be doing. And they have more time, most people, although, you know, people are working more and more, they're working fewer hours a week, so there's still more time for the other things that matter more. And this has been shown time and time again. I'll show you a study in a minute. For those of you who are saying, I don't believe this, I'll show you a recent study in a minute, and explain that your response isn't atypical. So next one, most people, and people do look at this and they're like, no, they don't believe it, right? So either we're based on evidence or we're not, but the facts are the facts, and it keeps being shown. So we have to challenge ourselves, like, why don't we believe this? Why do we see facts and claim to be evidence-based clinicians and not believe it? Okay, most old people are sick and or disabled. So this is adults over age 65. I mean, obviously, if you took adults over age 85, you would have fewer healthy, more chronic illness, and more frailty. But this is for everyone over age 65, and it raises a big point that when we use the word old, we tend to use it as, like, it's everybody. It's everybody over age 65. Well, my oldest patient has been 111. And the 67-year-old I saw last week is nothing like the 111-year-old. So it's not just one big category. Also, under chronic illness here, this includes people with hypertension, with some knee arthritis, with hyperlipidemia. So most older people are pretty healthy and functional. Indeed, these are the disability rates. So any disability, 38%. But that includes hearing difficulty, which is quite common, but the fortunate people can afford hearing aids. And again, some of the Medicare Advantage plans, having looked at the data on hearing, which leads to social isolation and decreased cognition. So people with hearing loss who don't get hearing aids tend to get their dementia 3 years earlier than people without. So hearing aids really matter, so that's why they're paying for them. But anyway, the rates of disability are not what most people imagine. When I show this to medical students, their faces just, their jaws drop. It's not what they think about old age. Self-rated health. So these studies were just reported last week or the week before in Kaiser Health News by Judith Graham, who does really great work there. If you're interested in aging, you should definitely be reading her regularly. And what she pulled together a bunch of studies, but particularly the National Health Interview Survey data from 2017. People aged 65 to 74, 84% rated their health as good to excellent, and just 18% of fair to poor. Now, 18% is a lot. That's about 1 in 5. So do those people matter? Absolutely, they matter. And those are the people we're going to see more of. But when we think about old age, most people think about it the other way, right? There might be this exceptional 18% that really feels healthy and fit, and everybody else is miserable and sick, right? But even if you look at people over age 85, it's still 3/4 of them rate their health as really good. Now, here's what happened when Judy Graham's article went up. So she says, she tweeted out, the first 2 people to comment on my column today on my Facebook group both attributed the results I discuss here to denial. Simply can't believe these results might be true of older people, right? So a person's perception of themselves doesn't matter, or this is denial. And what these studies find is people adjust. Like if you're 83, you're not expecting your body to function the way it did when it was 33 or even 63. But what people find, and the people who are happiest as they age, is that they adapt. They think, how am I doing compared to what I thought 83 would be, compared to other 83-year-olds? And most importantly of all, because people focus more on their priorities, they think about, can I do the things I love most, even if I have to do it slightly differently than I used to do it? And if they find they can, they rate their health as pretty good. Old people are all pretty much the same. Anybody know who this is? Yes. So this is him in his hundreds, and I'm going to go backwards here. 90s, 80s, later 70s, earlier 70s, later 60s. So all of this is considered old age. This is one guy, right? It's not the same. How is it that we treat old age as a single category? That is insane, right? When we talk about kids, childhood lasts maybe 20 years. What do we say? We have a whole language for that. Neonate, infant, toddler, kid, tween, teen, young adult. What do we have for old people? Over age 65, old. Makes no sense. Right? You got to push back. Okay, so now I'm going to show you some centenarians. This guy you may have seen on YouTube or Google or somewhere. He was a guy in India who took up running in his 80s and started running marathons, which he did well into his hundreds. Okay, so clearly exceptional. Like, I don't think I could do this now. So I'm not saying, like, let's all go out and run marathons, but I'm just showing a range here. So there he is. But here are people, his neighbors in their hundreds, also in wheelchairs with a variety of disabilities. Similarly, this is a centenarian who has reasonably advanced dementia, and this is a centenarian who's still working his farm in Sardinia. So you can also think about these blue zones, places where people keep working, keep active, eat healthily throughout their lives, and more of them live to a happy, healthy, very old age. This is a centenarian who did everything right, and so she gets to be 100. And this is a centenarian who won the genetic jackpot, right? And she's so right. Like, if she's been smoking all these years and she's 100, what I would say as her geriatrician is, keep on smoking. Like, you have won the genetic jackpot. You are genetically superior, and aren't you lucky? I do tend to tell people like this, though, that we cannot guarantee your children inherited this, so your children and grandchildren should stop smoking. But you can do what you want. You're special. So there are so many ways we get into old age, right? We also tend to think biology is destiny in old age. When something goes wrong with an old person in the hospital, we say, oh, that's because they're old. So this is the classroom in which I had much of my medical school training. And what I learned about was the 70-kilogram man. I like to call him Norm. Now, this Norm has gained some weight, as many Americans have over the decades since I was in medical school. But we also learned that human beings came in two flavors. They came in kids and adults. Norm, I'll also say, was always male. He always was 70 kilograms. He was pretty much always between the ages of 20 and maybe 45 or 50. He was always white. He was always heterosexual. He was always Christian. He was always many things. And people like Norm absolutely matter. But so do the 90-some% of other people on the planet. So this is a curriculum from, I can't remember, it's either Harvard or Dell Medical School for current rotations for medical students. And it looks pretty much just like my rotations looked in 1990, and pretty much just like my father's rotations looked in the 1950s. And yet the demographics of our population, as we have seen, have changed dramatically. So we're still all learning to deliver babies, though most of us don't do that. And we're doing all sorts of other things. And I'm not saying these things don't matter. I'm just saying, shouldn't we align rotations with health needs and health usage? How else will we train people to meet the needs of the populace? And isn't that the point of healthcare? So how does this also play out? So these are the CDC's vaccine recommendations. They have 17 subcategories for children. They have 5 for adults, and then there's over age 65. And just recall Kirk Douglas between the ages of 65 and 101, right? We have a single schedule for that. That's just discounting older people. We know the immune system changes. The subcategories for adults and kids have to do with health-related behaviors. Those too change in old age. They have to do with physiology. They have to do with all kinds of things. And yet we just think, oh, these old people, they don't matter. We're going to give them a single category. That is social injustice. That is prejudice. That is ageism. And that's not right, and we need to change that. So I already spoke about the NIH rule. So this is the one that has been around for a while, but we do have now inclusion across the lifespan. Now, I always thought pediatrics was a century ahead of geriatrics, but it turns out the American Academy of Pediatrics was founded in 1930 and the American Geriatric Society in 1942, so not that different, right? Kids as percent of US population, 23%. Okay, more kids, great, you know, we need kids. Elders as percent of US population, this should actually say 16%, I mistyped, and going up, as you may have heard. Hospital stays per 100,000 population, a little over 2,000 for kids. That's good. Like, who wants to see a kid in the hospital? That's horrific. Hospital stays per 100,000 population, 26,500. So many more older adults, right? And people say, oh, yeah, it's a drain on the system. You know, our education system is used disproportionately by children. And our work-related systems, we have a lot of work-related systems and institutions and traditions used disproportionately by adults, right? Why are we blaming older adults for the service they need? We have different needs at different ages. We all have rights. Current membership of the American Academy of Pediatrics, nearly 70,000. Current membership of the American Geriatric Society, about 6,000. This is ageism in medicine. Here's a huge need, and people are walking away from it. So what I would like to leave you with, I have 1 or 2 more slides, I will get to Steve Jobs, is that the greatest limitations of aging come from our imaginations and policies, not our physiology. Not that physiology doesn't matter, but how we respond to it is creating the old age people dread and fear. Okay, so back in the day, this is 1950s, this is what computers looked like. And then things got a little better and they looked like this. I remember these. I actually sort of remember these because there was one computer at my college and I had a boyfriend who was an engineer, and it was a whole city building long, this machine, and it had this constant humming, and I don't know, he went and did something with it periodically. My father got one of these and never used it because he couldn't figure it out. He was a physician. Reasonably well-educated person who tried hard for several weeks and then gave up for the rest of his life. Got more and more problematic, but anyway, that's a different story. You know, but then this guy came along and he was like, what are we doing? You know, just because something has a function doesn't mean it has to be ugly. And if it can do these complicated things for engineers, why couldn't it do something for everybody? So we could do so much for old age this way. Because of the age I am and because of what I do, people are constantly coming up to me and saying, you know, my parents are in their 70s or 80s or 90s and they're doing okay, but we know like something eventually will happen, right? Because human mortality is holding steady at 100% and usually you get sick first. And they won't make any modifications in their house. Well, the modifications are ugly. They're like screaming, you know, it's so unnecessary. Why are we not using design to make things, you know, fun to use? And that would be great. Like if a little kid wants to safely get in and out of the bathtub, they could use the same thing. A pregnant woman could use the same thing. If you sprain your ankle, you could use the same thing. They should be in all houses. This is really a failure of imagination. So if we could apply, you know, Steve Jobs had his, you know, downsides, admittedly, but he did have an imagination when he looked at things that made them bigger and better and universal. And that's what we need for old age. And I will just close here with a quote from James Baldwin, who said, people who treat other people as less than human must not be surprised when the bread they have cast on the waters comes floating back to them poisoned. We've done this to old age for too long. and we should stop because, oh, that's weird. That did not do that yesterday. Anyway, there are three major categories of life: childhood, adulthood, and elderhood. And every time we invoke childhood and adulthood, we should evoke elderhood also. And with that, I'll stop, and I'd be happy to take questions. Thank you. Yes. Right.
So the third thing that I think is really challenging for older adults is sleep.
Yes.
Everyone has insomnia.
Mm-hmm.
I think that's so crucial to help them with that. I'm wondering how you work on that because sleeping pills are clearly insomnia.
Yeah, sleeping pills are so problematic. So we know they lead to falls and confusion, and they don't really help with sleep, and they have hangover effects. And then this actually raises another thing. So over-the-counter medications have lots of warnings for kids and pregnant women and people with certain problems, but they don't have warnings for the older people, and the sleep medications all have Benadryl, which is on the Beers list of things that you should not take when you're older, and yet the FDA has not put that on the labels. Okay, but that was a slight aside, sorry. So this is again an area where we know behavioral change is the single most effective thing. Your sleep architecture absolutely changes with age, but we do all kinds of things that don't affect it. So there's a great program at UCSF now, which is a 6-week sleep behavior change course, and it's working for people of all ages. Does it work 100%? No, but her data for the last couple of years is about 80% helping. So that's, again, something, and people have to pay out of pocket. We do have a low-income fund that supports people to go to that. But that's the sort of thing that should be paid for by insurance, because if you sleep better, you function better physically and cognitively. Now, if you're pre-oping someone like a week or two before their surgery, that's going to be tough. We do also have something called a prehab clinic now, which is sort of like rehab, but you do it before surgery to increase somebody's functional status. And so then you do have a time frame that enables sleep hygiene teaching. But certain really basic things about sleep hygiene help a lot. It's also critical to review their medications and the timing of medications, because medications and side effects also disrupt people's sleep. And some people are very religious about when they take them in ways that aren't advantageous. Thinking a lot more about when hydration happens can make a difference, which sorts of foods, caffeine. So as our metabolism changes, even a morning cup of coffee for some people may affect their nighttime sleep. I could go, that's like a whole lecture on sleep, so those are just a few thoughts, but absolutely critical. I completely agree. Thank you. Yes.
Really appreciated your talk, and
Thank you.
especially at the beginning where you're talking about the contribution of medical care in keeping people healthy. And I'm a public health prevention doctor, and even in our own state here in Oregon, the legislature is about to finish up its work, and we have not invested in the public health system. So most of what you're talking about, that first graph,
Yeah, it was public health, not medicine. Absolutely.
and community health,
Mm-hmm.
where actually live, work, and play. In our state, we totally underfund public health. As a matter of fact, I think on the docket, public health was only asked, this is the governmental public health, only asking for $50 million. I think they might eke out about $10 million.
Mm-hmm.
But the whole thing is, by the time somebody gets a medical doctor, and I'm a medical doctor, we need help supporting the health of our people that we see, our patients, including our elderly. So when that elderly person leaves your clinic, how do they go and take the Tai Chi classes and all that kind of? The medical system is not set up to help with that kind of arrangement and to support the community. So, I'd like to emphasize that and ask you to comment on that, and thank you for saying.
Okay, thank you. So the comment was really about the disproportionate impact of public health on health compared to medicine, which has been known. And again, in other countries who have better health outcomes, they have greater emphasis on public health and things that we call social care, in contrast to medical care. And yet budgets here in Oregon is just typical of the whole country. It's very small for public health. And colossal for medicine, right? And that's, you've got to add together all the medical systems. So hopefully, there's a lot of talk about population health and community health, but they're not putting the dollars there, and the dollars don't go to public health. I sort of like to use how physicians are paid. You can go to Medscape every year and see the relative salaries. And basically, what we prioritize in this country is certain organs and diseases. And orthopedist who, just sets bones, which I'm not to say that's not important, but can be paid 7 times a psychiatrist, right? A psychiatrist deals with your mental health, your ability to function and live as a human being, right? A radiologist will make 5 times what a pediatrician makes, right? Is it really 5 times harder or more important to read an x-ray than to keep a child healthy, right? So this is across the boards. We have, if you're saying there's going to be maybe 10 million for public health in Oregon, public health which does so much to help health. And for medicine, I mean, who even knows? Billions probably in a single state? I don't know. So thank you for your comment. Yes, over there. Mm-hmm. Yes, so that's a great comment. I actually usually mention about the failings of geriatrics itself, and I neglected to do so. So the comment was the Beers criteria, which is this list of drugs where they don't say don't give them in older adults, it's just think about it. But it again is that thing I was talking about, is lumping all people over age 65 into a single category, when if we know anything, it's not about the number of age, it's about your functional status, your number of comorbidities, the state of certain of your organs. Gait speed and grip strength are better predictors of an older adult's health, chance of hospitalization, and chance of death than any of our standard medical metrics. So your point was very well taken. You don't think you're 64 and 300 and something days, right? And then suddenly you can't take the drugs on that list. And I also think it's what happens commonly with lists that are recommendations to have a second thought. I mean, some of the drugs on that list, you should have a second thought for adults too, right? And then others, if a person's 66 and it might really help them, that's great. And maybe even if they're 81, although perhaps less so. But this happens frequently where people will do preliminary work or suggestive work and it will be made into law because of this great vacuum of better advice about how to take care of older people. So do I think we should look at the Beers thing and think twice? Yes, but do I think it needs to be sort of religious as a doctrine? I completely agree that it does not. There was another question over here. Yes. Ah. Mm-hmm. Right, so the question is about all the money that is spent. A huge percent of healthcare dollars in old age go to the last 6 months or year of life. Not for everybody, but for a lot of people. We actually know that this happens commonly. It happens more commonly to people who don't have advanced directives and haven't had time to think about how they want to live and die, and how they don't want to live and die. And it's again a thing where we'll pay for the intensive care and all the stuff that racks up costs, but we won't pay for the important conversations. And this may take more than one conversation. Actually, it probably should take more than one conversation. People should probably think about it, and they should get to discuss it again with someone they know and trust as their life changes, because it also happens that people think, oh, I could never live with, let's say, a feeding tube. Well, if the feeding tube is because you have advanced dementia, then we know that's not good for you. But let's say you smoked long ago and you have a swallow problem due to a cancer that was entirely curable, and you're otherwise working and feeling well. So I met a patient like this in the early 2000s, and it changed my thought. And she said, I had on my advanced directive I'd never have a feeding tube, but now I have a feeding tube and I'm going back to work. So you can't have these hard and fast things, but we need to spend a lot more time planning, and planning for old age more broadly writ too, right? People need to start doing balance training probably in their 50s and strength training in their 40s. We could have a much longer, happier, healthier, and more fit old age if we were actually paying and incentivizing people to do these things earlier on. At end of life, a lot of people in this crosses cultures think if you don't discuss death, you won't have to die, right? I mean, it's almost that Sarah Palin moment. But in fact, we all have to die, and you're much more likely to get the death you want and to avoid the things you don't want if you discuss it. There are even fun ways of doing this, like the Go Wish cards that families can do together. And I've had people who've been married to each other for 60 years learn really important, interesting, novel things about each other, and certainly adult children about their parents. So if this were just a normal part of discussions and they started way early when they seemed more theoretical and less terrifying, that would help. There are states and small communities that have put into these advanced directives, sort of universally community-wide. There's one in the Midwest, and I'm forgetting where, but their healthcare costs at the end of life went down, to 15 or 20% of what they had been previously, and suffering went down with it. So sometimes you're dying and there's no amount of modern medicine that can help. And we also know that, hospice has limits in that it says, well, if you're getting some certain sorts of treatments, you can't have hospice. Well, we should be able to have palliative care and hospice and standard medical care simultaneously. Just because you're dying doesn't mean you don't deserve certain treatments. So I really think we need to rethink how we do all that, but it's again coming back to not prioritizing and paying for all these procedures and completely devaluing the discussions and relationships and behavior and psychological stuff that really improve health and lives. And I should probably stop now because we're over time, but thank you all for your attention.